I'll just carry out this presentation on behalf of Fiachra. As I say, unfortunately, he couldn't be here, but it is very much dealing with the pricing considerations for 2024 and indeed into 25. So again, I've kind of covered a couple of these in my own presentation about the price list being the first true post-COVID price list. And really the issue there is, as I say, in the past 3 years, we've been just inflating the 2019 cost data to come up with a price list in the absence of, I suppose, to ensure stability in the pricing, number one, but also the fact that we weren't running a budget model because of the fact that the activity was down and cost was up. So I've pretty much said that. The key piece, I suppose, is that because we inflated the price list by typically a percentage each year for the last 3 years, then that can lead to movement in the DRG prices. Because essentially what we were doing was keeping the same relativities because everything just got inflated by a percentage. It was 5% or 7%, then the same relativity between DRGs remained. Obviously that changed when we carried out our 2022 costing exercise. But more than that is the issue that the DRG classification system changed. And that's a key point. So if somebody is trying to monitor maybe a price of a particular DRG from last year to this year or from 19 to this year, we need to take those factors into account. And that's really about the impact of the gross inflation. So I showed this morning about the move from 8 or DRG 8 to DRG version 10, 807 DRGs to 795. So essentially, it looks like just a drop of 12 DRGs. The reality is 89 were introduced and 101 were dropped. So, and within that, there was changes as well to the whole complexity regime and how they apply the complexity score. So Mark would have talked about, you have an A, B, C, D. We take stroke. So A is the most complex, B is next complex, and C so on. And the price differential reflects the complexity. Now in Australia, the way they do this when they move from versions of groupers, it's very much done on cost data. So they look at are there certain cases with certain characteristics within an existing DRG that need to be taken out and maybe created a separate DRG. So it's always cost that is driving the clinical cost and obviously clinical similarity. We still keep all the cases in the same specialty in the same DRGs, but that splits between the ABCDs is done primarily on cost. So what changed? Many ADRGs. So within our existing classification, we had pre-MDCs, which were really all your kind of major heart transplants, liver transplants. And the reason they were pre-MDC was that small numbers, so very much you expect that the price year on year will significantly fluctuate. AIDS, like heart transplants, probably about 160, 170,000 euros. So if you have a small number of cases, they're going to flop around year on year. In the new system, they just put it back in with the specialty to keep it all in the same MDC. MDCs are basically specialties. So essentially, we've got 26 MDCs, which broadly cover the range of specialties. So in most cases, the new A or DRG is a modification of an older one and can be mapped reasonably easily. So that's L42 ESW goes to an N43 nephro, anyway, whatever it is. I'm sure someone's clinical in the audience will help us. So some will be fairly existent and others won't map too well. A or DRGs have had complexity splits removed or added, and that's the point I've made earlier about, again, because that underlying complexity model is updated, that will lead to a lot of movement between DRGs in the version 8 to version 10. And that's always a challenge if people are looking back over periods, that when the classification change, it is very hard then to do that kind of back mapping. It can be done, but it takes a lot of work to kind of basically regroup cases into the new DRG system. So if I give an example of this DRG I13, we can see that in the old version 8, there was just an A and a B DRG. So there was 600 cases in I13A and 4,197 cases in I13B. So in the new version, that 686 cases that was in the old system has split over 3 DRGs now. Essentially, 222 in the A, 378 in the B, and 86 in the C. And likewise, in the B, none of those have gone to the A, as you'd expect, and 473 have gone to the B, and 3,700 to the C DRG. So that has major implications for both the price and the length of stay of those DRGs. And when I said earlier that these DRGs were basically designed based on cost, that is really reflecting the movement in costs for those patients between the different versions. But also the fact that we've 3 DRGs as well is allowing better specificity to allow us pay a different price for those DRGs. So you can see as well that the movement in cases impact on length of stay. So obviously if we take cases out of the A group, that means the ones who are there are more complex and will have a higher average length of stay. Hence the length of stay goes from 10.5 to 19.7 days. And to follow on, if the length of stay goes up, then the price goes up. So the price goes from 12,570 to 21,239. And the same applies then for the different DRGs. So obviously the makeup of the patients impacts on the length of stay and also the price we pay. And like the biggest factor, we talked about length of stay earlier and the importance of, being able to manage your length of stay and control your length of stay, is that length of stay is the key driver of cost in most DRGs. We've mentioned the common weighted unit. I think I've covered this earlier, and Mark has covered it, so I'll keep going on that. And the hospital factors. We've done this as well. So again, Mindful Fiachra was carrying this out. So I'll just go on to the consultation paper, which we haven't really covered. So again, the whole price list we mentioned earlier would be on the HPO website. It is used for ABF reporting. So again, the monthly reporting that we do, that Lorna does on the ClickView document that everybody has access to. The treatment abroad schemes. So again, I know there's some colleagues here from the treatment abroad. And that will be important as well, just with the piece we've discussed earlier on about price changes in relation to the different versions that, if we have people looking at, this was the price last year and look at the price this year, then we just need to be able to socialize that. I think for the main ones within the treatment abroad scheme, there isn't huge movement. So, but still, it's something to be mindful of. The pricing framework, again, I sort of covered that this morning, and again, it'll be on the website. The consultation paper is the one I just want to cover here. So this is really where we set out topics for consultation about the 2025 pricing framework, which is really the benchmarking which we carry out in 2024. So the 3 areas are individual DRG prices, phase, reduction in value of uncoded activity. I think Mark sort of mentioned that earlier, and work in progress. So we are saying, look, submissions to that website, ABF consultation by the 31st of August. Individual DRG prices, and this is where I expect we could get, as I say, some queries around, the price of this DRG has moved. Obviously, some of that is down to the fact that we have actually changed the classification system. But notwithstanding that, I think if people have an issue with a DRG price, that they maybe a high volume DRG for their hospital, then really the best way of making a case is to have patient level costing data as a primary data source. And I know David Frawley mentioned that earlier on about the importance of having patient level costing. And really that's the best way of making the case, because obviously the patient level costing is what's used to set the relativities in the first place. And I just a note there that the price list is based on A or DRG version 10. Obviously, capital and depreciation are out of scope for ABF, so shouldn't form part of the submission. The phased reduction in value of uncoded activity. So this is one that I think Mark mentioned, where we have uncoded cases. We don't know what DRG they fall into. But we do know that it is either an inpatient or a day case. So up to now, we've been giving 80% of the CMI of the hospital for inpatients and day cases. Obviously, that will change now because we've got a common weighted unit. But the question still remains around, is 80% too generous? We don't know, because it could be a very low value DRG. The reason for doing an 80% is to give some value, because we know that patient did incur, we would typically know the length of stay for the patient, but ultimately we don't know the complexity. So we give the 80% to recognize the value of uncoded activity, even though the nature is not knowing. We are trying to reduce the likelihood of overfunding uncoded cases, and we certainly don't want to do that when at the same time we're trying to incentivize coding, timely coding of data, because as Jackie said in her presentation, hype data is used for more than just ABF. It's used for a lot of other factors, including on the clinical programs, NOCA, Department of Health, and so on. So not having a fully coded data set does hinder that process. It is more important as well, for that reason, that the hype does provide a complete picture of acute admitted activity in the hospitals. So I guess the proposal for ABF 2025, which is basically this year's benchmarking model, which feeds into 2025 funding, is that 80% reduces to 70%, 60% the year after, and 50% beyond that. So I think really what we're trying to do there is encourage complete coding, and also to ensure a fairer benchmarking model, that we're not over, even at those 50, 60, 70% rates, we're not overfunding or rewarding somebody for not having a case coded. Mark did say that in other countries, if it's not in, you just don't get it. So I think, we obviously acknowledge the issues around, coding resources, and in particular, I think it's Jackie's slide where I think cases went up 7.7%, or maybe 60, 70,000 cases. So that has obviously put a substantial strain on our coding teams to get that level of activity coded. It's great that we can report it, because Stephen referenced the IGES report, which kind of looked at 16 to 2022, which when us knowing 2023 data had gone up so much, is a good thing for, in terms of efficiency and, again, accounting for and treating patients, obviously. So that's what we're proposing in relation to the uncoded activity. In relation to work in progress, I think Mark touched on this in his talk as well, about we always have patients in beds at the end of the year who were not discharged, and obviously they may not get discharged until later in the year, or even some following year. So we have this issue of, we work on discharges. So basically that's the currency. When the patient is discharged, DRG is assigned and we make the payment. So obviously for those patients who cross over the year end, there's no discharge, but the hospital has incurred the cost for those patients. Now, the flip side is, at the end of the year, you'll have patients, at the other year, you'll have patients who are discharged in, let's say, January or February, who were admitted in November. You're going to get the full value of that case. So there is an element of swings and roundabouts, and swings and roundabouts works to a point. But ultimately, where you have some very significant lengths of stays, I think Mark mentioned about a patient having 5 years in Vincent's, that totally distorts the picture, both for the hospital and indeed for the other hospitals in that group who they're being compared against. That patient possibly for 5 years, Mark, could have got a value of over €1 million, potentially, depending what the DRG fell into, because we pay a per diem beyond the high boundary point, which if that was 20 days, they basically got, whatever, 1,500 days above the high boundary. So that's clearly distorting for that hospital, but also for the other hospitals, because again, in that year, they're now being compared against something that's happened over a 5-year period. So I guess what we're really saying here is we're going back to the accruals concept for activity in the same way as we would for expenditure. And I think it's also distorting as well that the monthly reports we were given back to hospitals, that if there are some patients with very high lengths of stay that cross over year ends, when you come to look at that analysis at the DRG level, it's going to distort that picture. Now, it was good that, the hospital identified it. I guess it fairly stuck out like a sore thumb if it's 5 years, but I think there can be a number of those patients, and particularly we know all the challenges within the Irish health system of trying to move patients, from the acute setting into the community. So really the proposal around the work in progress is that we move to a kind of an opening closing stock WIP payment. So essentially we ensure that the payment hospitals receive reflects the cost within that year. And I think that's something we'll monitor, but it will take a bit of work, because obviously we've got to track all the patients then who were in the hospital at the end of the year, what the length of stay were prior to the year starting, and the same at the other end. So it'll take a bit of work, but I do think it'll be a fairer reflection, and particularly as transition rates decrease, and that's part of the reason why you'd have transition rates, is to iron out some anomalies such as this. But I think the more we can kind of chip away at those anomalies, the better the model will be. So that's the proposal on that. How to make a submission. I've said this already through ABF consultations. And end of August, really. Submissions should be clear and concise. Description of the position of the submitter and substantive backup material. There's no point in saying, no, that DRG is wrong, or, you got to give us a basis so we can actually go away and look at the data, compare the data from your hospital against other similar hospitals to see, is it really just unique to your hospital, and so on. And look, the process we're following here is pretty much what they do in the Pricing Authority in Australia. And the final one I just covered then is just the quality-based funding framework. And this is about, again, putting the patient at the centre and anything we can do to improve quality, whether it's through funding or not. But ideally, we should be trying to use funding to improve the quality, whether it's the best practice tariff, an outcome-based payment, value-based payment, payment for performance, pricing signals, price incentives, normative pricing. They're the typically ones that are used. But to do that, I think you have to have some principles in relation to, you can't have best practice tariffs for every DRG. So I think it has to be a clinical priority. There has to be then clinical oversight as to what are the criteria to allow you get that payment. Measurability, can we measure it? Data integrity, is there funding available? We pay a co-payment for the hip fractures at the moment, but again, that's not taken out of the pot for ABF. It's an additional payment on top of that. And I think they need to be time limited. So essentially, if you're trying to bring in that quality piece, then after a certain period of time, it should be part of the ongoing process and not require additional payment. So that's really it. I think that's all I have on that. As I say, it's never easy to fit in for somebody else, but I'll leave it at that for the moment. And if anyone has any questions, I'm quite happy to take them. Sorry, Jerry is one there. So just wait till you sit back there.
Sorry. Jerry Kelleher from Business Intelligence for the Clinical Programs. Is there any opportunity for nudge-based funding models which would help hospitals shift left. And if they don't want to shift left, they'll actually lose money by doing them in the higher cost location in the hospital or community.
Yeah, I think we'd need good systems in the shift left places. Because really, while we have good data within the walls of the hospital, we're not necessarily able to not necessarily able to track the patient when they leave the hospital. So I do think with the individual health identifier coming along, that will certainly assist. But really, we do need to be able to track the patient when they leave the hospital. In fact, even within the hospital system itself, Jerry, we can't track patients outside the hospitals, which is an issue for us, because one of the quality factors we would look at would be readmissions, but we can only see readmissions then within a particular hospital. We can't, if a patient was discharged from the Mater and went to St. James's, we can't pick that up. So I think the IHI coming in will be a key piece, but obviously you still need the systems behind that to track that patient into the community. But I think with the movement to the regional, what do they call it, health authorities or health region areas, whatever they're called now, and you've got the one funder, then I think there's a big incentive within that region to ensure that if you can, ensure the patient is treated in the most appropriate setting at the lowest price, well then that's beneficial to your budget control. But I do think we have an issue just around as I say, the tracking the patient when they leave the hospital. But I do think as a principle, it does make sense, yeah. Okay, I'll leave it at that. Thank you.